All right, welcome everyone. Thank you so much for watching this video. I'm so excited to share this interview with you with Dr. Linda Isaacs. She is board certified in internal medicine. So she's a real MD. She worked with the late Dr. Nicholas Gonzalez for over 20 years using an individualized diet protocol, high doses of proteolytic enzymes, and a detox and supplement therapy. And I'm just really excited for what she's going to share with you today. And so welcome, Dr. Isaacs. Thank you so much for being here.
Thank you for having me. I appreciate the opportunity.
Oh, my pleasure. So you are a obviously well-established author. You have written in multiple journals and published books even. So do you want to share a little bit about maybe your favorite thing that you've ever written so far?
Well, one of my favorite articles, actually looking back on it, was one that talks about how to recognize a case report that is good quality.
Yeah.
And the reason I say that is because, it can be frustrating to me sometimes when patients or people will hear about a particular testimonial in favor of some treatment, whether it be orthodox or alternative, and not really recognize that the story is either extremely convincing or not convincing at all. And so I wrote an article about how to recognize a good quality case report, and I am rather fond of that article. It's something I'm glad to have written.
Yeah, that's great. I was actually just reading that article, and I think it's very important. I'm going to put it on my website because I think it is really important for people to like you shared about the woman who went on to have long-term survival after having a breast cancer surgery and doing no chemotherapy or radiation, and that was her expected prognosis anyway. Whereas if she had done chemotherapy and lived 3 years, then that was actually rather exceptional as well.
Right. It all depends on what you would expect for a particular patient. So there's a lot of people that think, for example, that getting surgery for breast cancer cured them when in fact there's a big problem with overdiagnosis where they're finding cancers that would have never hurt people in the first place. And so the water is a little bit muddy, and I just feel like people need to know that before they put their faith in a story that they heard, so to speak.
Yeah. And then Dr. Gonzalez wrote about that also because someone had asked him, I think it was him, for a 5-year statistic. And he said, yeah, sure, I'd be happy to do that. So he was asking about breast cancer, and he was like, so which type of breast cancer do you want to know about? And then that really stumped, then he went further into the different types.
Yeah, he and I wrote an article together about statistics and why it's not such a simple question and answer. That's right.
Yeah. So do you want to just briefly go over, the meat of that article that you wrote?
Oh gosh. Well, the article about statistics was just trying to answer the question that we would get asked all the time about, what are your statistics for X, Y, or Z? Bear in mind that the protocol that we do is a lifestyle protocol. In other words, people need to modify the way they eat. They have to take a lot of pills. They have to do detoxification routines. And all of those things take time and energy and persistence on the part of the patient. Not everybody actually follows through, and it's always hard to know exactly which patients do and which patients don't. But I don't believe that anybody would expect a treatment to work if the patient didn't do it. So that is a huge variable in terms of creating those kind of numbers. Also, patients, your typical big medical center that does a big study to evaluate their particular treatment, they have to recruit very large numbers to have it mean anything. And so large numbers of patients for a small practice, which such as ours, that's just not going to be possible. So what we've tended to focus on over the years are case reports. They're patients who have done way beyond what's expected in terms of their length of life, or patients who have had resolution of disease. But it's case reports, and not an idea of how many people exactly like this have we treated and how many did well. because there's simply too many variables, and in many cases not enough of an identical group of patients to be able to give those kind of numbers.
Yeah. Eventually, though, there was a study that was attempted where there was a preliminary study, and then there was funding by Nestle, I believe, to do a clinical trial on the high enzyme in individualized diet protocol. And, because, the powers that be, they're not too interested in alternative methods succeeding. You also wrote a book about what went wrong. Literally, the book was called "What Went Wrong There," in an effort to prove the efficacy of your therapy. Unfortunately, it didn't go as planned. So what happened in that, just briefly?
Okay, well, just to give your audience some background, Dr. Gonzalez and I worked together for many years offering these protocols, which use pancreatic enzymes as the base of the treatment, but also involve dietary changes and detoxification, other supplements as well. And Dr. Gonzalez, after 6 years in practice, had presented 25 best cases at the National Cancer Institute. And based on that, the doctors there suggested that he proceed with what's called a pilot study in pancreatic cancer specifically. Now, pancreatic cancer was a cancer that we had focused on from a research point of view. Simply because it's very consistent in terms of what happens to patients with this particular illness. Breast cancer or prostate cancer, for example, can range anywhere from very slow to very fast. But pancreatic cancer, unfortunately, is pretty universally nasty, and so it was the cancer we chose to focus on in terms of research efforts. So we did a pilot study. What that means is that there was no control group. The only group that we were following were the ones that we were treating, and then you compare it to historical controls. In other words, what happens in the general medical literature or in the big databases of cancer outcomes, so to speak. And so we treated 11 patients in our pilot study, and our median survival was 19 months as compared to in the neighborhood of 7 to 8 months with pancreatic cancer under ordinary circumstances. And just to give you an example, another study that was done around the same time, looking at the results with a drug called gemcitabine, none of the patients in that study, and there were 165 patients, as I recall, something like that, in that study, none of them survived more than 19 months, but we actually had patients that survived 4 and 5 years on our treatment at the time of publication. We had people that were still alive. And so based on the results of the pilot study, the National Cancer Institute and what was called at the time the National Center for Complementary and Alternative Medicine funded a study that was going to be a more direct comparison. In other words, patients would be recruited at the same time, and they would either be doing our treatment or they would be doing chemotherapy. The problem with that study was that we were not in control of recruiting the patients. And I think that would have made a huge difference because we've had a lot of experience over the years in figuring out who's most likely to actually follow through and who isn't. The patients, they were understandably rather desperate because pancreatic cancer is a terrible illness. But some of them really, I think, were either in denial or misrepresented how well they were doing physically. As an example, there was one patient who was entered into the study. When I asked him how he was eating, how well he was taking in food, he kind of paused. And then his wife chimed in and said, "Tell her you're eating 3 meals a day, honey," because that was a criteria for the study. The reason being that if patients can't eat, they can't take the supplements. And if they can't take the supplements, how are they going to get any effect from the supplements? They're not going to. We're very dependent on patients' ability to eat. So that gentleman was unfortunately admitted to the study, and a week later he was admitted to the hospital because he couldn't even keep fluids down. And he never really started, but he was still counted in effect as a treatment failure because of the design of the study.
Mm.
Dr. Gonzalez actually wrote a rather lengthy book about this study called What Went Wrong.
Mm.
I wrote a shorter article called Research Battles, which was
Mm.
published a few years ago.
Mm.
But the study was poorly designed. The net result was that a lot of people were entered into it that didn't actually follow the treatment. And of course, it seemed to look like our treatment didn't work. But in fact, the vast majority of the patients that were assigned to it didn't follow it.
Mm. Mm. Wow. Well, so much for statistics being helpful.
Yeah, and I understand why patients ask. You know, they don't want to invest time and energy into something that's not going to work for them. All I can really say to that is that part of what I do with patients is I offer them, you know, as a screening tool, the opportunity to send in information about themselves, which I'll take a look at and say whether or not I think I can be of help in their situation. Um, the types of people that I would typically not feel like I could help would be, you know, those who are simply too ill. And unfortunately, I get a fair number of applications like that. Also, if somebody has a condition where orthodox medicine can be curative, then I'm going to tell them to do that. So, for instance, you know, patients who have a localized breast cancer, surgery can completely cure that. And I think it would be irresponsible of me to encourage them to follow a nutritional approach that may or may not work and that they may or may not follow. For them to do that in place of a treatment that might just take care of the problem, you know, I really think I need to tell them to go get the surgery.
Mm. That's interesting. So I'm not sure if you were aware, but my mom submitted my medical history to be a patient of yours and Dr. Gonzalez's in 2011, and I actually wasn't accepted as a patient. But you know, I don't know if it was because of prior treatment. Is prior treatment another factor that you consider?
It can be. It really depends on the circumstances. And, you know, again, I'm glad to see you're doing so well,
I think.
obviously. I'm glad you found something else that worked for you. That's wonderful. I don't have any recollection of the discussions that he and I would have had around your situation at the time, so I really couldn't answer that.
Mhm. Okay. Yeah. So, because there was one patient I was reading about who had prior chemotherapy, who was a patient of yours or Dr. Gonzalez's. So, is there like a certain level of treatment, or that you can gather from their medical records to determine if they're going to have the best chance of?
Well, it depends on the diagnosis to a
Okay.
large degree. Like there are some diagnoses where if they've had prior treatment, it is we just, you know, on a practical level, we've tried to treat certain situation, you know, certain conditions that have had certain treatments and it hasn't worked, you know,
Mhm.
and so there does come a point at which it's just not in the patient's best interest to try.
Mm.
That's what we believe.
Right. And
But
motivation.
it's hard for me to, you know, spell it out exactly
Yeah.
because
Right.
it really depends. And there are some conditions, like for instance, some of the leukemias where patients can be extremely unstable at the time that they're diagnosed.
Mm.
And we would routinely tell them to, you know, get the treatment, get stabilized, and call us back.
Mm.
Because, you know, if they're in the hospital with infections and needing transfusions, you know, there's a time that you need orthodox medicine.
Right. And level of motivation is a factor as well, right? Because it's a very difficult, or it's a more intensive regimen than some others, might be.
Well, certainly, if somebody approaches us with the attitude that we need to talk them into doing it, then that's going to be a reason to tell them to move on.
Mhm.
Because the reality is, you know, I can't go move in with anybody or be
Mhm.
there for them on a moment by moment basis.
Mhm.
And to do any kind of a nutritional approach, you've really got to be committed to it all the time. You know, if on Monday you're very motivated and you know doing all the things you need to do, and on Tuesday you say, "Oh, the heck with it! I'm probably dying. I need to have a piece of chocolate cake to cheer myself up." if you're going back and forth like that, it's not going to work. And so for people to come to me expecting me to provide the motivation it's just not realistic. So part of what we're looking for is a patient who is motivated to follow through.
Okay, great. And how important is it to follow the nutritional program, and what have you seen when people have gone off of the diet that you've prescribed?
Well, I think with any treatment, whether it's orthodox therapy or an alternative therapy, you're never going to know if it would work for you if you don't do it. So I think that failing to follow through on directions just adds a level of confusion for everybody. So all I can say is that I think that if you really want to know if something's going to work, you've really got to do it. There's just no other way. I think that's probably the simplest answer. I've had patients over the years that try to skate along the edge of compliance, and I understand that there's a constant pressure. Every night when you watch television, there's going to be 15 ads for food. It seems like half the ads are food and the other half are pharmaceutical. And there's going to be advertisements. There's going to be pressure from friends and family. There's going to be pressure from time commitments or just being hungry and not having anything available and thinking you want to rush out and get a hamburger at a fast food restaurant. So all of these things are constant temptations. I understand that, but the reality is that patients are going to have to figure out a way to keep themselves on track.
Okay, great. And so the individualized diet is a major component, but would you say that you can't, pick and choose what you do and don't want to do from the protocol, but another important tenet of it is the pancreatic enzymes. So do you talk about the trophoblast theory and why the enzymes are so important?
Okay. The trophoblast theory actually stems from the work of a Dr. John Beard. Dr. Beard was an embryologist. That's somebody who studies the very, very early stages of development. So from the time that the sperm and the egg join together to form the embryo, then that's the beginning of what embryologists study. And so the reason why Dr. Beard got interested in cancer was because he observed that at a very early stage of the placenta, the connection between the mother and the baby in humans and other mammals looks and acts a lot like a cancer. And that tissue is called the trophoblast, so hence the trophoblast theory. The trophoblast then, its job as the embryo travels into the uterus is to latch on to the uterus, to dig its way in, and to create a connection, a blood supply between the mother and the baby so that nutrients can go to the baby and waste materials can go out. That's the trophoblast's job. So it invades, it creates a blood supply. Well, cancer does the exact same thing. And Beard actually, he passed away in the 1920s, but he was doing these observations in the early 1900s. So he noticed that these two tissues were very similar in the way that they looked, but there's one big difference. Cancer just keeps going, but the trophoblast stops. At a certain point in development, the trophoblast stops the invasion, matures, turns into the placenta, which then at the time of delivery just neatly peels itself off and is expelled, leaving the uterus intact for another pregnancy to happen down the road. So the trophoblast matures, it changes. And Beard thought that if he could figure out what the signal was that would get the trophoblast cells to stop invading, then he might figure out an answer to cancer. What he found when he looked at a lot of different things that were happening in the mother and the baby at the time that this change happened was that at the time the change happened, the baby started making pancreatic enzymes. Now, pancreatic enzymes in typical physiology are believed to only have a role in digesting food. But here the baby is making digestive enzymes months before delivery, months before seeing any kind of food. And nature tends to be conservative. In other words, the lungs aren't ready to go until the last month or two of life. But here the baby's making pancreatic enzymes at 2 months into a 9-month gestation. So Beard theorized that pancreatic enzymes might have a role against cancer. He wasn't a physician, so he couldn't try it out for himself, but various other doctors at that time tried it. What they found was that sometimes it worked and sometimes it didn't. Beard's comment when it didn't work was that, well, you must not be using good quality pancreatic enzymes. There were some available at that time. They were used for other purposes, but the quality varied a lot. There was no refrigeration commonly in use at that time, and so the quality of the enzymes varied. Beard said in some of his writings that what people needed to do was go to the slaughterhouse, retrieve a pancreas, chop it up, and administer it to the patients. You can imagine that most doctors don't really want to do that. And so the net result was there was a lot of back and forth about, does it work, does it not work? In the meantime, radiation came along and was billed as an easy, universally effective, non-toxic treatment for cancer. Well, it's not easy, it's not non-toxic, and it's not universally effective, but it created a lot of stir, and during that stir, Dr. Beard's work was pretty much pushed to the side. Over the years, though, various other people have tried to treat cancer with pancreatic enzymes with some very positive results. I'll also throw out there that in the last 10 or 15 years, there have actually been some articles looking at whether whether cancer and the trophoblast are similar. It turns out that on a biochemical and molecular level, they use a lot of the same mechanisms to invade and to create a blood supply. And it also turns out that both types of cells, cancer cells and trophoblast cells, have receptors on their surface for proteolytic enzymes, protein dissolving enzymes, of which pancreatic enzymes are partially made up. So it does look like that. My prediction is that regular medicine, basic science, may actually swing right back around to where Dr. Beard was 100 years ago if we give them another 10 or 15 years.
That would be so cool. And I found in my research recently something very interesting. I was trying to find the normal range for CA-125 in, an average person. And I found this article. It's a research article called, I don't know if you've heard of it, Cancer Antigen 125 during pregnancy in women without ovarian tumor is often not rising. And I start reading it and I see this chart where they have the gestational age on the x-axis, and on the y-axis they have the level of serum 125. So if you can see it there, like the CA-125 is high in the early gestational age, and then it drops and it's more consistent later in the pregnancy. And they reference a couple different studies, and there was one done in Iraq in which a normal pregnancy between 4 and 10 weeks gestational age, the serum CA-125 was averaged at 74, and the average for someone either not pregnant or in the second or third trimester, the average is like 25 or 35 or around there. So I thought that was a really cool find, which further supports the trophoblast theory, how cancer is just like a trophoblast, and so that when an embryo is in those first, was it at about 8 weeks when they start producing the pancreatic enzymes?
That sounds about right.
Okay.
Dr. Beard was looking under the microscope. It turns out that some other investigators in the 80s and 90s looked at the same question and found it even earlier.
Okay. Because someone asked me, their CA-125 level was increased and they weren't sure if that was because they had cancer or if there was another reason. So that's how I came across this article, and I found out about this research on pregnancy, and I said, well, I don't know what, if you may be pregnant or not, but this is possibly another reason that you have elevated CA-125. Is there anything else that you've come across that might potentially increase the cancer marker? And,
Well, the tumor markers in general, there can be a lot
right.
of non-cancer reasons why they're elevated. I know with CA-125, there's quite a long list,
Mm,
and so it makes it pretty unreliable as a screening tool.
okay. Okay, I was just curious.
Yeah.
Thank you. So, how important are coffee enemas on the protocol and why?
Right, coffee enemas are a vital part of this protocol. What we believe is that when pancreatic enzymes start doing their work, they create waste materials. And those waste materials are biologically active and can make a person feel like they have the flu, just general low-grade aches and pains and et cetera. And if they're just allowed to accumulate, people can get really sick.
Mm,
And so the coffee enemas are a way to stimulate the liver and the biliary system to help get rid of waste materials.
mm,
Now, most of our patients actually find that they really like them. No one ever believes that when they first come in, but most of our patients find they feel so much better when they do them that they're actually happy to keep doing them once they try it.
yeah. Like my mom tried to get me to do a coffee on a book before I went away for treatment. And I was like, you are sorely mistaken if you think I'm going to start this now when I don't absolutely have to. But then once I started trying them, I realized how good they can make you feel. So I've,
Mhm.
continued them long term over 8.5 years. So
Mhm.
I have experienced that benefit. Is there, um, do you prescribe it by symptom or just a general number?
Well, the usual pattern for most of our patients is to do it's two smaller doses. So there's different directions by different people, but we have people do two doses in the morning and another two in the afternoon.
Okay.
So that's the usual starting point for those.
Okay. And those are, so they're back to back, two back to back?
Yeah, right.
Okay.
It
Okay.
takes around 30-40 minutes along in there
Okay. Great.
total.
Okay. So this is a question I uh, don't know how exactly you could answer, but for because people have asked me this question, they want to know how to use pancreatic enzymes themselves if they can't see you as a patient. So, what would you say for someone who is interested in your protocol, who is not accepted at a patient for one reason or another?
Yeah, anything that I say that can be construed as me giving advice to people that are not formally my patients can actually be a way to get me into quite a bit of trouble with the medical boards.
Mhm.
So I can't really answer that kind of a question. It's just not, it's not the way medicine is practiced. And the reality is that, if I have to waste a lot of time and energy of fighting with medical boards, I'm not taking care of patients, and that's really what I want to be doing.
Yeah.
So, I'm afraid that I can't really give specific instructions for how people can treat themselves.
Thank you. And are you able to apply the therapy to all types of cancer, or is it more specific to certain types?
Yeah, well, I would say it's all types of cancer. I mean, there are a few types of cancer that I am not currently choosing to treat just because the results have been, not the best. Glioblastoma is one of them, for example. It's a particular type of brain cancer that's very, very aggressive, and I just haven't been sufficiently, pleased with the results with that one to want to continue to try. And there's some interesting experimentation going on in the regular medical world that might be a benefit to those folks. But generally speaking, it's more about the patient who has the disease as opposed to which disease it is.
Mm, okay. Um, so some of um, the nutritional protocol depends on the balance of the autonomic nervous system, and it generally follows a pattern, right, with solid and liquid tumors.
Right. The autonomic nervous system is one of the things we take into consideration when trying to design a nutritional protocol. The theory behind it is that the autonomic nervous system is frequently out of balance in one direction or another for patients that have developed a cancer. The autonomic system, the sympathetic, the fight or flight system tends to be overactive in patients with carcinomas. So that would fit into such categories as breast cancer, lung cancer, colon cancer, prostate cancer. All of the ones that are called carcinomas tend to be in patients that have an overactive sympathetic system. So the sympathetic system is the one that helps us respond to stress, but it also tends to shut down the digestive system, shut down the secretion of pancreatic enzymes. And so those patients, in order to be brought more into balance, will do well with an alkalinizing diet that is more on the vegetarian side. The patients whose parasympathetic rest and digest system when that system is overactive, what that will do is tend to make the body more alkaline and tend to stimulate the immune system, which sounds like a good idea, but not when it's overstimulated. That's when you get things like leukemias or lymphomas. Those patients need a diet that makes their system more acid, and that would be animal protein. So, at various times, it's been interesting over the past 25 years doing this. There were times that I've had to argue with patients who thought that everybody should be on a vegan diet. Well, now there are other people that will say that everybody should be on a ketogenic diet. And there's all sorts of variants in between. We recommend that people stay away from soy because it has an enzyme blocker. And there was a time I would have to get into arguments with people about that. Now people seem to be fine with that one, but they want to say that drinking carrot juice is dangerous, which I don't agree with. So there's always different fads, so to speak, in the nutritional world. What we've been pretty constant with, though, is the concept that there are some types of cancer patients that do well with a diet that will make their body more alkaline, but there are other cancer patients that need a diet that will make their system more acid.
And when you talk about alkaline versus acid, that range is pretty small, right? Because our body tends to maintain homeostasis in a certain pH.
It is pretty small. The range is pretty small, and so I can't honestly say that we're out there measuring blood pH all the time. It's not that easy to do. The pH in the veins isn't all that accurate, and pH in arteries is painful and difficult to do. So that's not something that we've historically done. What we have instead, we just have a large body of clinical experience that tells us that one group of patients do well with a more vegetarian diet, not completely vegetarian, but on more vegetarian, and with a lot of magnesium and potassium, and that there's another group that don't feel well typically on that kind of diet and will do better with meat and with calcium as a supplement.
So how a person feels is often a sign of whether they're on the right protocol or not.
Well, it can be. I mean, your typical sympathetic dominant who does better with a more vegetarian diet with lots of salads and leafy greens and alkalinizing, like somebody who actually likes wheatgrass, for example, those patients can typically sense that they feel better on that diet and that they don't feel well when they eat a hamburger or a steak, because their digestive system isn't very strong. And so that hamburger or steak winds up just sitting there like a rock in their stomach. They just don't digest very well. Whereas the other group, the parasympathetic dominants with the very active digestive system, for them, a meal of carbohydrates just burns like it's gone. It's poof, a quick burst of energy and then gone. So what those folks need are protein and fat that will burn for a long period of time and give them a more steady energy level. So they feel great when they eat red meat. I've actually, when I've encountered patients with a blood disorder of some kind who I tell them that they can eat meat, and they look at me and say, Oh gosh, this is so wonderful. Last night I had a dream about steak with a baked potato and butter. Can I have the baked potato and butter? And I say yes, and they get all excited.
Mm.
Whereas if I tried to tell a sympathetic dominant patient to eat like that, they would be more likely to look at me and say, if I ate that for dinner, I'd never go to sleep. It just doesn't digest. You know,
Mm.
that doesn't feel good.
Mm. Wow. But then I believe you gave an example. I don't know if it was an introduction to a book or a book itself, but there was a woman you gave an example. Um, she went on the prescribed diet, and then I think it slowed her down because she had a hyperactive sympathetic nervous system, and she didn't like the feeling of going at a slower pace. Um, so, do you ever find that it's a challenge or kind of makes a person change their lifestyle a bit?
Well, your typical sympathetic dominant, they have the overactive stress response system. And so what that means is that their physiology is always kind of on low grade red alert. They're always ready to respond to something. If you think about in the animal kingdom, it's not too reliable to think about domestic animals because we're their defense system, so to speak. But if you think about a deer in the forest is constantly looking around in between bites of vegetarian food because it needs to look around and see what might be about to attack it so that it can run away. Or a rabbit constantly looking around. Is there a hawk up there? Is there a fox nearby?
Right.
Constantly on red alert. So that's what the sympathetic system does. It keeps people on edge, on point, so to speak. And for us humans, we can get somewhat addicted to that. You think of the phrase an adrenaline junkie. We all know people like that. They're the Energizer Bunny. They're run, 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 go, go, go. They've got a huge to-do list, and they're very proud of the fact that they can plow through it all. They're very good at overriding how they feel and just getting stuff done. The trouble is that what that can mean over a long period of time is that the parasympathetic repair systems never get a chance to do their work, and they wind up with different types of health problems. So what I'll be doing is trying to slow down the Energizer Bunny. For the Energizer Bunny, it can feel really, really strange because they're used to being able to do all this stuff, and to some extent their self-worth is tied up in all this stuff they get done. So when I slow them down, that feels really weird and they can resist. I think what you're talking about, there's a introduction that I did to the book Nutrition and the Autonomic Nervous System, where I was talking about a woman who she was on the protocol for breast cancer, and Dr. Gonzalez put her on the usual alkalinizing diet. But with that, she didn't have the energy to plow through her to-do list. So she would just feel a little tired. She didn't like that feeling. And people can reframe that as feeling peaceful, feeling more at ease, feeling calmer. But she interpreted it as fatigue. She said, this is bad. And she would go see other folks who would put her on herbs or medications or whatever to give her more energy, but then she would get into trouble with her cancer.
Wow, that's really interesting. So do you find that there is a spiritual component at all, or do you, I don't know, if patients, have these questions about that, or, some kind of emotional um, issue that needs to be addressed at times?
Mhm. Well, if you think about the autonomic nervous system, and I just talked about the sympathetic system, the stress response system, and that system will respond to any kind of stress. It can be emotional as well as physical. So as an example, if you found that you got really angry with somebody about something, or were really upset or anxious about something, you might find that your heart starts to beat faster, it jumps up in your throat, you break out in a sweat. All of those things are signs of that sympathetic nervous system turning on. So you would feel exactly the same way if you walked out your door and saw a wolf walking down the street. You get that sudden burst of energy and you jump back in the house. Well, you might feel the same way if you got mad about something. But that turning on of the sympathetic system is not good for healing. And so people that are constantly in a state of anxiety or fear are keeping that sympathetic system on all the time, and that's not constructive.
Mm.
It's a tough one though, because here people are handed a life-threatening diagnosis, and so of course there's going to be moments of worry, fear, stress, and anxiety. The question becomes, what do they do with it? And that can be a hard one to figure out for a lot of people. But some things like meditation or prayer or exercise are all documented to help in this area.
Mm. And that's not, and yeah, the diet, using the diet to address that is not to be confused with emotional eating, which can also have the same effect through comfort foods that aren't healthy, but rather using a prescribed diet to help mitigate that.
Right. Yeah, I would agree there. Yeah, the comfort food thing is not a good idea either, because usually it's junk food.
Right. Okay. And then there is, a lot of people have a question about, for certain types of cancer, more regular consumption of animal foods or red meats are prescribed. And there, like if you think about the blue zones diet, the populations in the world that have a large number of centenarians who live a long time, their diets are very low in animal protein. So what would you say to a skeptic who is probably more convinced that less meat would be better?
Well, I think that any kind of population study, you have to look at what's the population you're looking at. What are they primarily made up of in terms of their autonomic balance? Because if you look at a population that's mainly made up of people with an overactive sympathetic system, they're going to do better on a more vegetarian diet. And if you look at populations that have a more parasympathetic balance, are going to do better with more animal protein and especially with more fat. So the epidemiologic studies like that are quite prone to error because of unrecognized underlying factors. So what I'd say then is different people are different, and that's why the people that advocate a paleo diet, for example, will drag up statistics from some other study, and frequently it's done in a different part of the world. So if from my point of view, I find it interesting to notice that a study that seems to be supporting animal protein will typically come from a northern European country where a lot of the people probably came from the Arctic Circle, where if you're not willing to eat animal protein for months on end in the Arctic Circle, you're not going to last terribly long because there's no vegetables up there for a large part of the year. So I think that the other consideration is that, if that's true, then all of our patients, we shouldn't have any successful patients with leukemia, lymphoma, or multiple myeloma or melanoma. But we've had a number of patients with those illnesses that have done very well with a high protein, high fat diet.
Thank you for addressing that. And circling back to the beginning, I'd like to ask you how you got into medicine, and I guess I'd like to hear a little bit more about your journey, your story.
Okay. Well, I actually started off as an engineering major. I always knew that I liked math and science, but I didn't really know what I wanted to do with it. My father, while he was a career military officer, he'd started off in engineering. One of my sisters is an engineer, but the other one is a doctor. And I didn't really have a clear idea of what I wanted to do when I started college. Then I spent a couple of summers with my sister, the doctor. She got me a job in a research laboratory. And I got interested in biology and biochemistry. Then I took a biology course as a sophomore and realized it was a lot more interesting than what I learned in high school. And I came to appreciate, that in biology is, to me, just more interesting than just straight chemistry. That was, how I was feeling at the time. So I decided to apply to medical school. And, in some ways, medicine, many times people go into medicine because they have family members that had various illnesses or whatever. But for me, it was really more about the interest in the human body and in how it works and all of that. I really love medicine. My training is in internal medicine, and I thoroughly enjoyed that training, but my interest has always been to do this kind of work. I met Dr. Gonzalez when I was a third-year medical student. He was already engaged in his research into the work of our predecessor, Dr. William Donald Kelly, who was a brilliant orthodontist who he himself had treated himself for cancer. And then when he got better, his orthodontic practice turned into an alternative cancer practice because he had so many people wanting to know what he did and can I do it too. So he figured out a lot of the work that we've then carried on. I myself actually got sick after I started feeling unwell partway through medical school, and by the time I reached the end of my internship, I had a chronic fatigue syndrome. I had been very careless with laboratory chemicals when I was working as an undergrad in a biochemistry lab. And so I went on this protocol to get better, and I did. So between the case reports of the people that Dr. Kelly had treated, the patients that Dr. Gonzalez was treating, and the fact that I myself got better on this protocol, all of those things have worked together to have this be the path that I've chosen.
Wow. So was it your diet was prescribed according to your autonomic balance, obviously?
Well, yes. I mean, many people are actually more balanced. A lot of the patients that come in to see me are going to be one extreme or the other in terms of their physiology because they're not well. But many folks with a more like a fatigue syndrome kind of thing are actually reasonably balanced, which means that they can eat a wide variety of foods. And I would say I'm more in that category at this point. So I eat animal protein. I don't eat it 3 times a day, but I do eat it.
Right. So then what do you believe helped you the most to heal from the fatigue syndrome?
Well, I think that all 3 components of the protocol that I offer are important. I think it's important to eat properly because it gives you the fuel you need. It gives you the fuel, the nutrients. Diet is probably the biggest influence on the autonomic nervous system. But also, when you're eating properly, you're not bringing in things like trans fats or whatever sprays or chemicals or waxes or pesticides, all the different stuff that winds up in food that's not good quality. You're not absorbing it. You're not having to get rid of it. The nutritional supplements give the tools that your body needs to help repair, to fix things. And then detoxification, especially for me, was very important because, like I said, I had exposed myself to a lot of chemicals that I needed to get rid of. And some of them had recognizable smells that I could actually smell as I got rid of them years later. So that was a little interesting side note from that. There was one particular chemical that smells very much like rotten eggs. And so there were periods when I was healing that I smelled like rotten eggs. That didn't make me terribly popular. So detoxification is very, very important too. All of those things are important. And what I find, typically is that patients that decide that one aspect isn't important, they don't do well because they don't fundamentally get the big picture that it all works together.
Right. Have doctors come to you asking for training or information on how to do the same thing that you're doing?
Well, so far, Dr. Gonzalez and I were both, when we were together, before he passed away and subsequently for me, I've had a few people approach me, but they tend to want the weekend course, which isn't terribly realistic. What I'm potentially looking for is for the right kind of person, with the right kind of licensure for one thing, but to have somebody that is willing to come and work with me because that way, we can talk about things on a day-to-day basis. This is not the kind of thing that you can learn about over the weekend and set up camp on Monday. There's a lot more to it.
Right. So for young aspiring doctors, what would be your recommendation for them? Like would you train them or help them learn?
Bear in mind that I just moved from New York City to Austin, so I'm still readjusting myself here. But part of the reason for the move was to be able to have the space to do what I just said. Ideally, though, I think that to be a practitioner in this kind of work, first you should be a patient. I'm not necessarily saying that I think they need to take enzymes around the clock or anything like that, but to actually do things like coffee enemas, to actually do the various cleanses, to actually follow a nutritional protocol, because there's nothing like having experienced things to make it possible to explain things to other people with some conviction. So I think that would be one of the considerations in all of this that I would want them to be willing to do.
Yeah, that's great advice. I pray that God will send you someone to do that, to train under you, because the work that you're doing, it has a long history, and I just pray that it continues, and I'm sure it will.
Well, I certainly believe so, but I can also tell you that there are bits and pieces floating past in the medical literature that make me wonder if Orthodox medicine may figure out a lot of this one of these days anyway. So, one way or another, I'm sure it'll work out.
Yeah, I know that's happened with immunotherapy, like, Dr. William Coley, he had the Coley's toxins, and they're using that idea of immunotherapy, but it's still, it's not the same. But so maybe they will use something similar.
Yeah, it's hard to say. There is, like I said, some interesting work being done about receptors for enzymes on cancer cells, and that's exactly what Beard would have predicted if he'd been thinking about receptors on on cells back in that era. It's actually totally predictable in Beard's theory. One of the catches, of course, with that is that there's nothing patentable about enzymes in cancer because they've been used on and off for cancer treatment for more than 100 years. So that means that there isn't drug company money put behind it to try to develop it, unfortunately.
Yeah. Well, that's great. So how can people best support you? Is there anything that you would like for people to pray about for you to support you in your work?
Oh, well, thank you. I think that's the first time anybody's ever asked me that question, so I appreciate that. I think some of the needs are fairly obvious. I would like to be able to pass the torch to somebody else, but I want it to be somebody that I feel really good about, preferably multiple somebodies. So that would be nice. And I think just the ability to pass the work on is definitely on my mind, but done correctly. Poor Dr. Kelly actually tried to do exactly that, but he trained a large number of people, but unfortunately a lot of them just, they brought their own perspectives into it and didn't learn it properly. And then when they tried to implement it, it didn't work. And then they blamed the method. And so there's a big piece of me that doesn't want that to happen, but at the same time, I know I definitely don't want this work to end with me. And I would never retire and leave my patients in the lurch. But at the same time, it would be nice to retire someday. So I hope that the right person will come along, and I hope to be able to recognize them when they show up, and to have it work out, really.
Yeah, that's great, because aren't there over 4,000 questions on the questionnaire to determine the autonomic balance?
Oh yeah, Kelly's old questionnaire. He had a very detailed way of trying to figure out autonomic physiology, and we got away from using that a while back. I I think about that sometimes, but my own feeling with that, because many times I'll have patients come in and they'll tell me that they took that test and they'll tell me that they came out very balanced, but I'm looking at them saying this person is not balanced. They're very sympathetic dominant.
Huh.
And my speculation is that, during Kelly's era, it was actually okay to say that you are a hard driving, person that wanted to get stuff done. That was a cultural ideal. But now, for many people in the alternative world, and perhaps in the culture in general, the idea is more that you're supposed to be very zen, very balanced, very calm. And so I think that people answer the questions in a way that makes them look good, but isn't terribly accurate. Again, sometimes wonder if, they're answering that, oh, I'm very calm, I'm very peaceful, I'm very spiritual, and meanwhile their family members would be saying, yeah, right. So that's the catch with those kind of questions, is that people will want to answer them not always truthfully, but in a way that makes them look good. And unfortunately, I am more of a sympathetic dominant, so I'm insulting my own group by saying we're more likely to do that.
Well, I can't even take a personality test, evaluating myself. I'm like, I feel like I could answer yes or no to all these questions.
Yeah, well, people that tend to be more parasympathetic and tend to be more alkaline usually have a hard time making decisions. So
Oh,
perhaps that's an illustration.
yeah, maybe that's a sign. Well, Dr. Isaacs, thank you so much for your time and doing this interview and sharing about your practice and your work. And may God bless everything that you do and all of your patients as well. Thank you again.
Well, thank you. And I perhaps you're going to post this, but if anybody wants more information, they can visit my website, which is drlindai.com. So that's drlindai.com.
Wonderful. Thank you.
Well, thank you so much. I appreciate it.
My pleasure.